All right, guys, we're starting the third part of our lectures on behavior psychiatrics, and this one's a little bit near and dear to my heart. For those of you that don't know, I actually did my bachelor's capstone on firefighter suicide, and that's what we're going to be talking about is suicidal patients. And I'm going to kind of throw in some of the stuff about our particular suicide numbers, and it should probably scare you, and I hope that it does, because it's really important to take care of your mental health and well-being before you get to the point where you feel like that the only way to stop it is to kill yourself. Okay. Suicide is defined as that, as a person wants to intentionally take their own life. Third leading cause in the 15 to 24 age group, the ninth reason of death overall. And women attempting suicide more than men. Men are often likely to succeed. The ladies will threaten it. The guys, they'll find somewhere, usually with a bullet in their head. Okay. Or it will be a permanent where you can't undo it. Okay. So, and by the way, as a numbers deal, guys, these numbers are 3 times as higher for emergency service workers. Okay. If you're feeling this way, you need to get help. Okay. And by the way, so long as you have been my student, you pick up that phone and you give me a call. I assure you, I will be there and I will be happy to talk to you. Okay. Again, so your suicides, again, most of the time, the people that want to do it, it's usually a bullet. Poisoning overdose is one way. They'll strangulate. They'll try to choke themselves out. Cutting is very rarely a way that they try to kill themselves. Okay. Very rarely. Usually when they cut themselves, they want help. All right. And no, we can't teach the class suicide getting it right the first time. No, we can't teach that class. All right. So never lose sight that there is usually a psychological nature of the attempted suicide, okay? And critical to the patient's long-term psychological health is that we get to that. And usually they'll plan this out. And I think that that's kind of a dependent upon the situation. So what are some risk factors? Depressed, using alcohol, divorced, widowed, giving away of personal belongings, especially cherished possessions. They've done it before. Older people, by the way, or their age being that of 15 to 24, the teenage years, or they're very elderly. Okay. Again, if they're living alone or in increased isolation, and again, the presence of psychosis, again, homosexuality, yes, they're more prone to committing suicide. Major separation of trauma, major psychological stresses, they have loss of independence, lack of goals for the future. All of these things, suicide of the same-sex parent or family member, and expressions of the plan of committing suicide. If they say that they're going to do it, assume they're going to do it until proven otherwise. Okay. And again, possessions of the mechanism for suicide. Yeah, they're guns. They're, constantly out cleaning their guns and not for the purposes of shooting. Okay. That would probably be a warning flag. All right. So again, they really do need to be evaluated. And many people assume that they were just looking for attention. Well, unfortunately, you apply that to the wrong patient, and congratulations, you just killed them. So again, make sure you start communicating with these folks, okay? Continual reassurance and compensate for the patient's loss of sight or hearing with reassuring and physical. And when I say loss of sight or hearing, that they're not aware of their surroundings or their situation, okay? And sometimes it helps to bring that into perspective, okay? Again, treat them with respect. Call them by their name or their title. You don't want to administer meds to these folks, okay? Unless you absolutely have to. If they're getting violent to the point, that's a completely different story. But again, tell them what you're going to do before you do it. Take your time. And I think this last one is, if they are helpful, please enlist the family. If they're not helping, obviously you don't want to do that. So age-related conditions, again, the psychological stress and behavior of separating the young parent, the child from the parent, Usually a bad idea. Attempt to prevent a child from seeking things that will increase their distress, and then keep your explanations brief and simple, and then repeat them often. Let a reassurance there slowly. Let them know what you're doing, and whatever you do, don't lie to them. Be truthful. Be truthful. You know what? Yes, I got to put a needle in here. Yeah, it's going to sting for just a second, but then you're going to feel better. Okay. Again, and encourage them to help with their care, by the way. Reassure the child of all interventions and do it gently. Okay? So do not discourage the children from crying or showing emotion. It's okay. If it hurts, it's okay to cry. Okay? Allow them to keep their favorite blanket, toy, whatever works, and we don't ever leave a child alone. Okay? Period. We don't. Excited delirium. Ooh, boy. Yeah. So factors, again, usually it's because there's an increased dopamine levels in the brain, and to the point where I've actually watched a guy that was really small, maybe 120, 130 pounds, beat up two cops that are 300 pounds. And I ain't talking beat up. I'm talking they had to shoot him. Okay? They had to shoot him because it was that bad. And we got a front row seat to it. Okay? It is amazing that excited delirium patients can do all kinds of great physical things. And again, usually, this person was hyped up on PCP. But cocaine or other stimulants, they can exacerbate that delirium. Again, in that excited delirium, and they try to restrain them, that actually probably one of the worst things you can probably do. But for their safety, you have to. Okay. So again, they're going to have abnormal tolerance to pain. So even if you apply a painful stimulus, it ain't going to work. They're going to be usually breathing fast. They're probably going to be tachycardic as well. They're going to be sweating, agitated, and their skin is going to feel hot to the touch, okay? Yeah, they're not going to take orders, especially not from police usually. They don't get tired. They have superhuman strength, and probably 7 out of 10 times they've got inappropriate clothing. So again, allow the patient to struggle, is a factor, by the way, for sudden death. Okay, so you really do need to tranquilize. You need to beware of the patient that actually becomes tranquil after they've been fighting like this, because at that point you got to make sure that they didn't go into cardiac arrest. And yeah, that's probably what happened to them if they do that. So how do we manage these folks? All right. So ensure the scene safety. Again, make sure that that you got to calm, provide support, treating the existing medical conditions, and don't let the suicidal patient be alone. We don't want to argue with them. Again, we're there to help. Okay, we're not there to judge. We're not there to, but we're there to help. Okay, take that stance, and you'll be surprised how much better this goes. Be truthful, speak in direct, simple manner, and transport to an appropriate receiving facility. Don't take them somewhere where they don't have psych services. It's bad. Okay, treat the whole patient and never overlook the medical issues that might be going on. Now, the slide here, it has to do with the ranges that you might actually get, all the way from combative to completely withdrawn, where they're not even saying anything to you. So you have to understand that you got to know where you're at in this continuum. Now, a tasered patient, less lethal way of law enforcement subduing somebody. It uses a small amount of it disrupts the voluntary control of skeletal muscle, and it can cause minor injury because the prongs do go inside the skin. Okay. Direct injuries impacted the probe. Again, they're usually a small puncture wound where this happens. The unfortunate problem is it never fails. They either shoot them in the boob or in the crucial 1% area. And of course, those being extremely sensitive, that usually requires a facilitation to transport to the facility for removal. Okay. By the way, usually when they're tased, they usually fall down. So don't forget about that for secondary injuries. And again, remember that the danger of ignited combustible gases. So yes, they can set off flammable areas with a taser. Okay. And it's a very high voltage. There's very little amperage that goes through it. There are very few watts that go through this. So it's a very minute, your pacer supplies more milliamps than the taser does, guys. Okay. So again, Assuring the scene safety, again, make sure, before you release somebody to law enforcement, you can remove the taser probes. Yes, that is you can do that. Simply hold the skin taut, pull, twist and pull just a little bit. Usually the taser barb comes right out. But again, before you release them, their heart rate needs to be below 110, the respiratory rate needs to be below 12, and the Glasgow Coma score needs to be 15. If it doesn't fit that criteria, guess what? We shouldn't be sending them. O2 sat should be above 94. You should have a good blood pressure above 100 systolic. Dart did not penetrate the eye, face, neck, breast in the females, axilla, or genitalia. In that case, we need to take them to the hospital for surgical removal of those areas, okay? Ensure that the taser is no longer active. As dumb as that sounds, there's nothing like getting zapped. Again, make sure you're wearing gloves, grasp the taser barb, and just quickly pull straight out, perpendicular to the surface. Again, a Band-Aid to cover it, and clean it with an antiseptic solution, and then cover it with a Band-Aid. Usually 24 to 48 hours, they take care of their own issue. Usually if somebody gets tasered, more than likely they're going to be going to jail. Okay, if they don't go to the hospital, they're going to jail. Okay, again, treatment for overdoses. Make sure the lacerations, toxic inhalations, anything like that. They may have chronic psychiatric conditions, and when abused, that can have very toxic side effects. Tricyclic antidepressants, MAOIs, SSRIs. If they've overdosed on one of those three, any psych drug, you really need to take them to the hospital. Really, really need to take them to the hospital. There should be, well, we're going to let such and such take them. No, you're going to need to take them if they're on, especially the big three that I just named, okay? Approach the patient, introduce yourself. Be calm, cool, collected. Make sure that you have a way out. Make sure that we don't talk down to these folks. And that's going to take some practice to do, okay? Again, you're there to help. If you keep that stressed in your brain, you'll be fine with these folks, okay? If the patient senses or uneasiness or indecision from you, they're probably going to act out on you, okay? So never play along with a hallucination, okay? Never, never, ever. No. Even I, as a seasoned paramedic, know better than to do that, okay? That gets really bad really quick. And if you do play along, I assure you will lose credibility. I promise you will, okay? Restraining a violent patient. Boy, there is some major controversy about that, about doing that, okay? And again, I think that we teach you defensive tactics for a reason, because there is a right way and a wrong way to do it, okay? And again, unexpected agitated patients, escalating emotions. Again, there are times when I believe restraints and physical restraints are necessary, as well as chemical restraints. If you've gone to the hospital, you've done your rotations, a lot of the hospitals don't allow physical restraints. The problem with that is, there are times when that is absolutely necessary until you can chemically restrain them, until the chemicals take over. Okay. So again, the best method is the least restrictive. Okay. That is the best method. And again, talk them down is the best way. Okay. Be calm, spend time with them, avoid direct on, again, don't get in their personal space. Talk to them, okay? Conversation, friendly tone, let them know you're there to help. It's amazing that how that works, especially the patient's suicidal or homicidal. Again, we need to make sure, we need to assess for that, all right? We need to know if a verbal intention sometimes defuses a situation or prevents further escalation, okay? Simply by talking, verbal judo, if you will. You want to talk to the patient, keep them talking. It's amazing once you get them talk. If you have to use physical restraints, again, soft restraints, the wristlets, the chest posy, hand restraints, again, you want to try to use the least, the restrictive as you can. Okay. I'm not a big fan of the handcuff in the back of the truck or handcuffing them to the stretcher. Handcuffed to the person, I'm okay with. Handcuffed to the stretcher, I am definitely not okay with. And if they are handcuffed in the back of my truck and they come with me, somebody in law enforcement comes with me, and that person, I have a key, and I make sure that they have a key before we leave. Okay. The physical restraints, again, you're going to have 5 people to do that. Okay. 1 to control the head, 1 to control each arm. Okay. And we're going to do that in DTAC. I'm going to tell you right now, it's probably one of the more fun things you guys are going to get to do, because we're going to fight the snot out of you guys. Okay. We should never, and I repeat this, never hog tie them. That's the hands and arms behind their wrist and legs tied behind together. And then we put them on the stretcher, or the scoop stretcher sandwich. We put a backboard down, we lay the patient down in a prone position, and we throw the scoop stretcher over them, and we strap the two together to where they can't move. Good way to kill your patient, okay? Very good way. We don't do it. Your patient should never be left unattended. If they are restrained, they never, I repeat, never are unattended. We constantly do frequent neurovascular assessments. That's every 5 minutes at a bare minimum. And if they're struggling against the restraints, that can lead to acidosis and fatal arrhythmias. So understand that, yes, you can make them. Once I get them physically strained, most of the time, by the way, guys, I usually will chemically restrain them. Okay, chemicals are better living through pharmacology. And in our case, Haldol, Versed, great drugs. Okay. Now, again, can we use other law enforcement officers to help us with this? Absolutely. But should we be using these things? Absolutely not. I have never taught you how to use a steel baton. I've never taught you how to use a taser. I've not ever taught you how to use pepper spray. So guess what, gang? You shouldn't be using this in the back of your truck. All right. So again, applying a pharmacological agent, whether IM, intranasal, subdural, again, there's lots of ways to give it. Okay, you don't actually have to have the IV started in order to do it. Now, if you got an IV started, it just helps things go a lot quicker. But again, there's sometimes we have to literally just give these guys an injection and let them do their thing. Okay. Now, again, chemical restraints. My personal favorite, actually, ketamine is ranks up there with mine. Benzos are great. I really like using the you can use an opioid, your Narcan, not Narcan, but your fentanyl. But I'm coming more of a Haldol fan, actually. So again, it kind of depends on the situation. If they're super duper violent, I'll either give them again, Haldol makes them just mellow and great and wonderful and cooperative. I've had good results with that. If you have a dystonic reaction with it, you can give them some Benadryl. It usually puts them right to sleep. It's still a win-win. Again, chemical restraints, and they need to be FDA approved for that, again, with your Peridol administration. You got to be careful with these guys, haloperidol can cause some arrhythmias, so that's one of the reasons they don't like to use it. In very severe cases, you can actually sedate and paralyze these patients to assure the restraining of violent behavior. I think you're going down a really bad hole here if you're having to go that, but I've had cases where we've actually had to do that. And again, you gotta look at the risk versus benefit here. Okay. And I think it is completely situationally dependent. All right. And again, it's the decision that's best less. I know that Dr. Frank is a big one on, let's give them something to calm them down. Okay. And he doesn't per se like using the physical restraints unless absolutely necessary. Okay. Psychiatric patients, in summary, it's probably one of the more difficult calls you're going to go to because there's so many ranging things that can do it. Keep yourself safe. Keep your crew safe. Address the patient's need. Okay. Even if they don't know what it is. All right. If they're suicidal, sometimes just sitting there and talking to somebody might be the difference between them overcoming that feeling and not wanting to kill themselves. Okay. Again, we don't forget that there may be a metabolic problem that's causing this issue. Okay. Never forget that. All right. If they're doing something so crazy, you know what? He got hit 3 days ago over the back of the head. Oh, I wonder if that's part of the problem. Okay. So don't forget about the physiological causes. Okay. Before just going up and saying, yeah, they're crazy. No, they're not. Maybe there's a reason. All right. The less amount of restraints, the better. Chemical is usually the ones that truth be known, we prefer verbal. Talk them down. Can't talk them down. Probably chemical is the way to go. Physically restraining, it requires a lot of effort, a lot of help. And I think that it's kind of an unsafe thing. It puts us into a dangerous position. Okay. And we really shouldn't be doing it. Again, make sure if you've got them restrained, we want to make sure that number one, stay restrained. But number two, and by the way, we never let the restraints up. Oh, you never, ever once you have crossed that threshold, I'm putting on physical restraints. You never, and I repeat, never, ever let those restraints up till you get to the hospital. Okay? Never, never, ever, ever. And by the way, these guys, when they get into restraints, they are Houdini. Okay? They are world-class escape artists. You'd be amazed at the things that they can get out of. Okay? So be careful with that once you do apply them. All right? Last but not least is these things, they can drain your emotions. They can cause you problems. Okay? Take care of yourself. All right? Get on a good exercise program. Work out. Take time away from this freaking job. Go do something that you like to do. And if you need help, don't be afraid to reach out for it. I cannot stress that so much. Don't be afraid to reach out and ask for help. I don't care how tough you are or how I've been in front of a lot of caskets with people that thought that they were tough. Okay? And it wasn't because they got killed in a bar fight. It's because they went out in the woods and blew their brains out. Okay? My simple short statement to you on this. If you need help, all you got to do is ask for it. Ask. It's there, and take it. Please take it. Okay? If you ever need it, if you ever feel like that, you give me a phone call. I don't care. Days, night, weekend, holidays. I can be laid up in a hospital. I'll talk to you. Okay? You got to promise me that. I will see you guys on the next one, and take care.